Okay.
Yeah.
Right. Hi, everyone. Welcome to the RoPat Ideation Panel discussion for our workshop on robot-assisted training for primary care, with the big question on how robots can help doctors in medical examinations training. I'm Florence, one of the workshop organizers, and we have Trish. Hi, Trish.
Yeah.
Hi, Thilina.
Hi.
Hi. Okay, we have Leong. Hi, Leong.
Hi, Florence.
Fumia. Hi, Fumia. Morning.
Hello.
Right, and we have Luca.
Hi, everyone.
Hi. And Simon.
Hello.
Perla.
Hello, everyone. Good morning.
Yeah, and also we have Josie. So unfortunately, Josie won't be able to join us today. Yeah, but she's part of the organizing team too. So yeah, as we all know, this year has been really strange and interesting with all the COVID thing and also the restrictions across all nations. Otherwise, we would most likely be flying off to Las Vegas today. Yeah. Well, despite not being able to attend the workshop physically, we are so delighted that we are all gathered here today live on our meeting. Our exciting discussions. So we have panel speakers from all over the world in both the clinical and technical fields. Thank you all for joining us today, and it is such an honor having you with us. So we also have workshop participants tuning into our discussions on YouTube live stream at the moment. So our participants are most welcome to interact with us by dropping questions or comments in the YouTube comment box, and we'll pick it up to actually address during this discussion. All right, so I am the chair for our first panel session today. Without further ado, let us begin with a brief introduction and sharing by our panel speakers. So in panel one, we have on the clinical side, Dr. Dhan Thiruchelvam from Newcastle and Professor Philip Chiu from Chinese University of Hong Kong. And on the technical side, we have Professor Kazuo Kiguchi from Kyushu and Dr. Mazdak Ghajari from Imperial. So I'll first pass the mic on to Dr. Dhan Thiruchelvam. Yeah, would you like to share with us an introduction?
Thanks, Florence. So I'm an upper GI and bariatric surgeon in Newcastle, New South Wales, but I was in Melbourne for quite a long time, and that's where Florence and I interacted on some research. I've got quite an interest essentially in robotics and how that can help medical training, in particular in relation to surgery. So there's been use of robots in surgery for quite a while, but its extension to even training medical students or junior surgical trainees or registrars is very important for a number of reasons. One, there's a decrease in overall clinical exposure to patients. Two, society demands that you know, gone are the days, even though I'm a young surgeon, I think that society now feels, look, rather than somebody in inverted commas practicing on patients, they really need to be training and learning those skills on some sort of simulation or robotic model. So I've got that interest, and in fact, Florence and I worked on some magnetic actuation models in robotics in Melbourne. So I think really the future of surgery is no more just the human surgeon and the patient. There's got to be a robotic interaction in between that for precision and training.
All right, thank you, Dr. Dhan. All right, so let's hear from Professor Philip Chiu.
Hello, everyone. Really nice to meet you here. I'm also an upper GI surgeon working from the Chinese University of Hong Kong. Florence, may I share? I have prepared a short PowerPoint slide. May I share?
Yes, please.
Yeah, okay. Okay. Can you see my slides?
Yes, you can.
Okay, so I'm going to talk a little bit about education and training in robotic surgery. And so this is when we introduced minimal invasive surgery in Hong Kong in the 1990s, the first laparoscopic cholecystectomy. And I think that is the time where surgeons actually taking out of their comfort zone and from the open to the minimal invasive era. And that's where also we are just treating disease with a small incision. So the
Sorry, Prof.
challenge
Chiu.
will be, yes.
Sorry for interrupting. Yeah, I think there is a prompt box on. Yeah.
Okay, so
Yeah, thanks.
is it okay?
Oh, yes, it is okay now. Thank you.
Okay, okay. So I think the training also changed over the past 20, 30 years. From the knowledge we learned from the seminar room all the way to virtual reality room training. And then we go through the surgical skill lab before any kind of operation being performed. And then we go on to the operating theater, and the surgeon will first be serving as assistant before they would be the chief surgeon who will be performing the surgery under proctorship. So, and I think what we are having now is in fact a upgraded system and also the tool that allow us to have a more precise and high quality of operation using the robot, the Da Vinci robot that we now have. So this is one of my procedure of performing a lymph node dissection over the right recurrent nodular nerve, which require a good quality and dedicated movement. So the robot actually provides with a very stable platform to achieve that purpose and a high quality of a surgical dissection, especially for quality lymph node dissection for cancer surgery. And so how can we bring this forward to train surgeons to use different kind of tool in the future? I think now with the different model of training, you have the simulation training for robotic surgery, and there are multiple systems that allow you to do so. While our center actually established the first robotic surgical training center outside US and Europe back 12 years ago. And we actually believe that we should not only focusing on the training of the tool, but also we need to bring the surgical procedure forward. So we are focusing on the animal model training and cadaveric model training, as well as to have a clinical hands-on training as well. So this is the number of training courses that we have organized over the past 12 years. And we are relying on simulation, animal model, cadaveric model, clinical case observation, and the proctorship. So there's always an argument whether simulation can help us to overcome the skill learning. We can learn some basic skill during the simulation training, but there are issues with simulation as well, because the surgeon will always think that this is not real, and they cannot overcome the variation in the clinical setting because of various kind of disease stage and also the anatomical and also the pathological variation. So animal model can help us to overcome and allow us to have a more real feeling of tissue handling. But we also face the problem of that this is not a real disease clinical situation. So we may actually be not able to simulate the real life dissection. And the animal model that we are using is mostly pig, and some of the organ cannot simulate the human. So the other option in the future that we may be considering, and of course for the panel discussion, is whether VR, AR, or even mixed AR, VR training should be adopted. And I think this will be greatly enhanced with the 5G technology, where we do not need to travel. Maybe we just have to be here in our room, and we can already situated over the training. That would bring the barrier for physical training. And the other is the model, whether you should be developing some robotic simulated model or 3D printed disease model that help us to overcome the changes in the disease and also the anatomical and pathological environment. And in the future, we probably also have some image guide robotic surgery. And this will also pose the challenge of the role of a surgeon for the next future, and how we should proctor and train the surgeon in the future. So thank you. This is my all my sharing. Thank you.
Thank you, Professor Chiu. That's a very interesting pitch on surgical robotics training. So let's move on to our technical speakers. We have Professor Kazuo Kiguchi.
Hello, I'm Kazuo Kiguchi from Kyushu University, Japan. So I'm an engineer, and I mainly work on human-related robot. One of the main research topics is rehabilitation robot, especially real-time estimation of motion intention based on biological signals of the patient is my interest. And that is very challenging to realize effective human-robot interface. And I'm also work on human motion simulator, such as human joint motion simulator, to investigate the optimal artificial joint replacement surgery or ligament reconstruction surgery. And also developing a laparoscopic surgery simulator for the practice purpose is another my interest. And especially I'm interested in mechanical properties of virtual model to generate a realistic force feedback. And furthermore, task evaluation in the surgery simulator is also interesting for me. So I'm glad to participate in this partners discussion today. Thank you.
Hey, thank you. Yeah, thank you for your sharing, Professor Kiguchi. So last but not least, we have Dr. Mazdak Ghajari.
Hi. Well, thank you very much for the invitation. It's a pleasure to speak here. So maybe I will be a bit of a fraud to this panel. So my background is mechanical engineering, and currently my research is focused on biomechanics of injury. So then how it is related to using robotics in medical practice. So I came to learn a bit more about this area in my collaboration with Frisch on RoboPatient. Actually, I learned that most of the skills that we have in biomechanics of injury can be translated and can be quite effective in addressing some of the challenging issues. So I'm pleased to see that, for instance, simulation was mentioned here. So one of the key methods that we are using in biomechanics of injury are computational modeling. So all the time, our purpose, our aim is to increase the fidelity of our computational models. So in situations where the forces can be dangerous to human body, of course, we cannot use human body. And we know that there are lots of limitations with the physical surrogate models that we have. For instance, one of the surrogate models that we often use, and perhaps you have seen in car crashes, is the hybrid 3 dummy. It is quite sophisticated, it's quite expensive, but we know it has major limitations. And now in some of the consumer testing, like NCAP or Euro NCAP, computational models of the human body, whole human body, is going to be used to rate vehicles, to rate cars. And I believe the same expertise that we have here on tissue dynamics, on modeling tissue dynamics, making precise predictions of the effect of forces on the human body on tissues, not in macro scale. We're also working on micro scale modeling of the effects of mechanical forces. So that can be translated into this area, and hopefully we can help to improve the robot-assisted medical training this way.
Great, thank you, Mazdak, for the amazing introduction. Right, so now we are ready for our discussions. And well, speaking of COVID earlier, we know that many people has been impacted by the situations in many different ways. So during a clinical interview that I had with Dr. Dhan Thiruchelvam a couple of months ago, we touched briefly on this topic. So it will be pretty interesting for us to further our discussion here. And yeah, let's start with Dr. Thiruchelvam. Would you like to share how the COVID situation and restrictions have affected your medical examination practice so far?
COVID has affected us in multiple ways. So one is obviously there was the stress associated initially with COVID coming on. That affected things on multiple levels. So in individual practice across New South Wales and Victoria or Australia, there was changes in clinical practice, changes in training. Some of the universities were saying to students that they couldn't attend clinical placements to try and minimize exposure. There's been changes in the types of surgery that were performed and the numbers. We're very lucky now, we're in New South Wales, we're actually back to complete normalcy. But the interesting, or I suppose it's not interesting, one of the sad parts to obviously what's gone on in COVID is that there's this huge wave of work that needed to continue. One interesting clinical scenario that came out of it was this shift towards telehealth medicine, so both consultation and otherwise, and it brought home some of the limitations of putting an interface between you and the patient. So that's important in both sort of robotics and clinical practice, but also discussion with patients. So I think patients and myself were very relieved to go back to normal clinical practice where you could see the patient and examine them. And so when we talk about robotics in surgery, that's an extension of the telehealth model, that there is a barrier, whether that be a virtual barrier or a physical barrier or a lack of haptic feedback or any of the number of things that we've looked at in robotics that changes how we practice. So it's been widespread, those changes during COVID, and I think we're only going to see more of that later as it progresses. So, yeah.
Okay, thank you, Dr. Dhan. And yeah, for Professor Chiu, how has COVID affected education and training in the side of medical practice?
Yeah, I think we share the same situation, that our medical student cannot come to the ward, and they would require a online training, but we have seen the deficiency of having the online courses because they could not appreciate the kind of physical sign that we can directly in contact with the patient, and also it cannot replace the real life physical training. So that has a tremendous effect. And secondly is that we are also limiting in terms of the preclinical surgical training because we did not actually organize any kind of physical workshop that trained the surgeons in terms of the new surgical skill, simply because we have to have social distancing. And so that also, the other thing that COVID affect us is that they drawn a lot of the clinical manpower to focus on management of COVID cases or prevention mechanism to spread of COVID within the hospital or in the community. So that draw a lot of our manpower, and that jeopardize the teaching, training, education as well. So I think these are important issues, and probably in the future, we also need to think about the solution of if there is any kind of situation that would happen again. So that may jeopardize a few years' time of medical training. And also perhaps there are increasing establishment or the acceptance of kind of online management or actually the AI and the robot. So I think that this is a time that we have to think about in the future, how we should adopt this technology to help situation like that.
Right, thank you, Professor Chiu. All right, so technically, Professor Kiguchi, can you share with us some of the strategies that you know in implementing robotic tools to assist remote physical training and examinations like this?
Okay. For the medical training, development of a robot patient will help remote medical trainings. Since physical contact with the real patient or subject are not required. And also the tele-examination, such as tele-diagnosis, has been already studied using a master-slave robot. For example, an ultrasound probe can be controlled remotely by a medical doctor using that system. So they will help remote examination. And telesurgery is also possible using a master-slave robot, such as Da Vinci robot. So that kind of examination or telediagnosis will be important. And also, if we have a robot patient, that will be very helpful for both diagnosis and examination, and also the training. And furthermore, the visualization of the patient physical condition using the certain sensors are very important. So if we can visualize the patient physical condition easily, then that will be very helpful for diagnosis and also the medical training also. So the robotic technologies will help to visualize the physical condition of the patient using the sensors. And robotics technologies will also help to evaluate the clinical skills. So for the training, evaluation of the skill is very important. So using the sensors of the robot, probably we can establish the way to evaluate the clinical skills. So that will be very important for the training, and that can be performed remotely. So that will be very helpful.
Right, great, thanks. Yeah, so all right, for Mazdak, how do you think our current technologies, for instance, AR, VR, could help robots, could help doctors in the remote platform for examination training?
Yeah, so that's a good question. So as you said, current technologies, so we can, of course, think about future as well. But currently, I believe we have good technologies in hand that can transfer some of the very useful information that usually doctors gain when they do face-to-face physical examination. For instance, we can have a view of the patient. We can hear the sound of the patient. Maybe one of the challenging bits is haptic sensing. And this is something that remotely is a bit of a challenge, how we can simulate it for the examiners remotely. So I think this third source of information is something that I believe the technology is moving towards it, but still we are not there. But I would say in terms of the auditory and visual information, we have the technology. There is already some apps out there. For instance, I know there is an app that is called the Good Sam. Actually, the inventor of the app was awarded an OBE recently. So this app enables normal people to make a call to the emergency center, and they just hold their phone on the face of the patient, and then the doctors just sitting at the center, they can see the heart rate, they can see this respiratory function, etc., and they can provide some advice before the emergency services arrive at the scene. So I would say that technology is already there, and probably we can start utilizing it. And as you mentioned, with AR or VR, we can give a bit of a better sense to the doctors when they're doing this examination remotely. But I think one challenge that we have, probably we'll discuss about is haptic sensing.
All right, thank you, Mazdak. So let's open up for questions from the audience or from any panel speakers who would like to chip in and discuss. So you can also type the question in the chat box and I'll read it out.
So
And
Mazdak,
sorry.
just a question for Mazdak. So one of the issues in surgery is really around the haptic feedback, right? So the Da Vinci, which is the most well-known robot, and there have been a few others that have come and gone, and there was one that came recently. I can't remember the name of it anyway. But it really doesn't get to the sensation levels that we require. So already during laparoscopic or keyhole surgery, we have a reduction in haptic feedback, and we've learned to deal with that, and same with the robot. But what is the barrier to getting appropriate real-time haptic feedback from a robot?
Well, I would say that's a difficult question. So what I can think is perhaps the sensors themselves. So I am familiar with a few sensors that are being used to measure forces. So haptic feedback, of course, it's the effect of the contact between two surfaces, and that is the pressure that is being exchanged between these two surfaces. So I think in the first place, we need reliable sensors to be able to measure these forces. But then when it comes to human finger, I believe it's such an intricate and complex system. So we should really get to the bottom of how the finger is sensing different objects, and then how sensors can simulate it for us. So we can put sensors, but when we collect this data, how we can then transfer it into perception of the sense that human perceives. And I think that is one of the challenges that I believe in the robo patient, that is one of the issues we are looking at. So with computational modeling, actually, we can then look at a fine distribution of the forces on the finger and how it is interacting with different tissues. And when we have several layers, for instance, in the abdomen. And then we want to translate it into the perception and see how we can link these two together. But I would say the main barrier to me seems, first of all, the sensing technology, and second, how we link it to human perception.
Great, thank you, Mazdak. So in terms of sensors and haptic feedback and all, so Professor Kiguchi, do you have anything to add?
Well, actually, in my opinion, force sensor must be installed on the tip of the tool. But in the case of surgery, it must be disposable sometimes. And or we need sterilization for the sensors. And that will be very difficult for sensors, basically. So we must study more about the force sensors for the surgery robot. I mean the practical force sensors. So the other method might be that another method to estimate the force, not directly from the force sensor. So for example, if we use that machine learning, we might be able to use visual information to detect the amount of force. So that might be another possibility. So not only the sensor itself, but also we must think about using that machine learning method. So that is another possibility.
Thank you, Professor Kiguchi.
Florence, leading on from Professor Kiguchi, I think that's important because when you talk about the hands, okay, we now really do a lot of stuff laparoscopically. So I do very rarely do an open operation. And if you're wearing 2 pairs of gloves, you're kind of muted. The difference in laparoscopic surgery is exactly what Professor Kiguchi said, is that there may be a lot of force on the instrument, but that force is related to torquing on the port rather than on the actual tissue. So the machine learning with the visualization is probably more of an indication of the force required to do the operation. So that's a very important point that I think Professor Kiguchi just brought up.
Thank you, Dr. Dan. So for Professor Chiu, so when you're doing like training and education with medical trainees, how do you actually interact and communicate with them when they're actually doing it on hands? And at the moment, with this remote thing going, do you actually use a platform to teach them, or like through visual cues, or even just through verbal?
Yeah, I think at this moment, when we are teaching the medical student online, we are using, in general, just like any kind of communication platform. Zoom is one of the most common, and I think in terms of the communication, questioning and the understanding, it is fine to use that. But at the same time, we actually lost a lot of the human communication through maybe a kind of body language or the gaze that we have. So also the minor point that we may be missing, especially when we cannot teach them physically through a patient's education. So that is one of the missing link for a medical teaching. And I think it cannot be replaced by the current technology. And at the same time, I think for the surgeon, we are actually teaching them inside the operating theater. When we are still running our operation, it is fine, but the issue is also because of the COVID situation, we are limiting our manpower. So maybe some of the procedure, because when we are having a high instance of cases of COVID, we are limiting the number of surgeons that are participating in the surgical room in order to avoid and lower the risk of the infection transmission. So that would also jeopardize some of their training opportunity. And also sometimes when we are operating on the case, we prefer to have a more experienced person to complete the procedure in a faster and a high quality manner. So they are actually jeopardizing the training opportunity as well.
So prior to all these lockdown and remote measures, how was your training experience like with students? So when you're using like surgical tools, as mentioned by Dr. Dhan and also Professor Kiguchi and Mazdak, so haptic feedback is really important, but currently we don't really have like a platform that has a direct haptic feedback. So do you usually use like visual cues?
Yeah. I am a little bit contrary to think that haptic feedback is important. In fact, we have been, with the start of the minimal invasive surgery, we have been taken away all this haptic feedback. So with the use of the two instruments, we feel something is not a direct feeling. And then subsequently with the robot, we are operating without any feeling. We just rely on our visual observation of the dissection and to feel like we are feeling. So there are a lot of, kind of senses that we can replace. And I fully agree that perhaps the image will become more important because image analysis will be a kind of maybe better data. I don't know, but the engineer can tell us maybe another good kind of data analysis with the image processing so that we'll be simulating the kind of feedback that allow us to achieve a same dissection quality for the surgical procedure using the robot.
Great, thank you. Okay, so I can see that we have a question from our participant through YouTube live stream. So this is from Luke Holland. Thank you for your question. All right, so I'll read it up. Clearly, there is a barrier in terms of haptic sensing, but I would imagine that the larger barrier is through the actuation of the haptic simulation to the doctor. Has work that you know of been done to represent this information through different sensory modality? Like, for example, representing the haptic information as a sonification or visualization that doctor could learn to understand. Yeah, so I guess this point has been also like discussed during our discussions with our panel speakers. And instead of using just haptic, we also use like visual and to compensate for that feeling. Yeah, so any of our speakers would like to add to that?
I mean, I think I agree with what Philip was saying, and in relation to that question, that a lot of what we see during laparoscopic or robotic surgery is the visual cues. The difficulty is how you train somebody in that, because Philip's probably of my generation, I think, looking at him, so he would have had some open surgery, some laparoscopic surgery, some robotic surgery. So we have had the benefit of touching the tissues and feeling and knowing the tension and then moving to laparoscopic and robotic. When you're learning, this is the difficulty when you learn straight up on robotic and you get somebody, it's how do you teach them that that is too much force and there are things that you can teach them on a screen, but I think allowing a robot, so the more modalities of information that you get, whether that's visual or feeling, the better. So, you know, I think but the visual cues will still surpass all of those, I think, moving forward.
Great, thank you, Dr. Dhan.
Yeah, I think I also agree and echo. Yeah, I same generation. I go through open laparoscopic and then robot. So we have the feeling of the tissue tension and how we would not be injuring by applying too much of the forces. But in the future, and not in the future, but now our young surgeon has already been trained. You know, just started with a laparoscopic and then going to a robot. So that feeling, that touch on the tissue handling is not as precise as we have, because we have the feeling of the tissue. So how do we actually, and the new generation probably rely a lot more on the technology. So as we see, many of them are actually holding their mobile phone all the way. So perhaps we need the technology that can be warning them that too much of the force, or that the procedure may not be best by performing in such a context. So maybe that would be requiring a AI or image, you know, analysis real time to give the surgeon a red alert, or to teach them or to monitor them how the procedure can be performed in a higher quality kind of surgical procedure as compared to the expert.
Actually, that was my question. So, of course, to the clinical experts, that which direction you would prefer the new surgeons to go. So, would you like them to practice more on the real thing and feel it and understand it, or would like the technology to progress like AI? Actually, I had that in mind, that maybe the robot can make decision for them. So, which direction you prefer?
Both, a mixture. So you have to think about it. You have to practice. You have to read it. You have to watch some visualization. You maybe practice it on some sort of simulator. But in the end, you are going to have to learn on a real patient. But I think putting all of those steps in, plus some AI, image overlay, exactly what Philip was talking about. Maybe you can have some guidance saying, listen, you're dissecting that cholecystectomy, but you're now getting too close to the bile duct, and you get, you know, like when you drive your car now and you go out of the lane and there's a warning, you know, sensors or whatever, similar kinds of things with image overlay. You know, I think so a combination of both. Yeah.
Okay, thank you. So as we are coming close to our second panel discussion, we'll wrap up with just one more question. So anyone has any questions so far for our panel speakers? All right, so yeah, thank you so much, panel one speakers and everyone. It has been a really interesting and exciting discussion so far. Well, so I will now pass the mic on to our second panel chair, Thilina. Thank you, guys, and on to you, Thilina. Yeah,
thanks, Florence. Hello, everyone. I'm Lalitharatne from Imperial College London. I'll be chairing this panel number 2. Beginning, for those who are in the Zoom meeting, if you have any question or comment for the panel, please unmute yourself and ask any question. And those who are joining with us through our YouTube live streaming, please feel free to type a question on the live chat section so that I can read them for you. Okay, and for the panel 2, we have 4 experts from both the clinical and technical background. I would like to welcome Dr. Tom Williamson from RMIT, Australia. And then we have Professor Jithangi Wanigashinghe from University of Colombo, Sri Lanka. And then we have Professor Chee from NUS, Singapore. And finally, we have Professor Simon Lusignan from University of Oxford, UK. I welcome you all. Before moving to the discussion, I would like to invite each of you to give a brief introduction about yourself, so our workshop participant can know about your background. Yeah, we can start from Dr. Tom.
Hi guys, yeah, my name's Tom Williamson. I'm an engineer and a roboticist. I currently work at RMIT University in Australia, in Melbourne. And my research and my work primarily focuses on automation in surgery and the development of robotic systems that can make decisions and perform specific tasks within surgery. And this has covered a range of different clinical applications, from ENT surgery and orthopedics and some abdominal surgery stuff as well. So a bit of a wide range of things. In terms of robotic patients, my interest kind of lies in a few different areas. I think that aside from the potential advantages that we've talked about with training and things like that, there's also the potential to get new ideas and to work closely with clinicians on virtual patients in situations that might be rare or difficult to access, to get new ideas to start developing new technologies for different clinical areas. Yeah, so that's pretty much me, basically looking at automation in surgery.
Yeah, thank you. Professor Jithangi?
Oh, hi everybody. So I'm Jithangi, I'm from Sri Lanka, and I am a child neurologist. So I think we have several surgeons in the panel. So as for my interest in this, I have not worked on robotics at all. I have minimal exposure to use of technology. I guess some of the work that we have been doing with Thilina and the team from University of Moratuwa probably was my only experience or exposure to use of technology. But I think I'm here to share with you about the scope of using robotics and technology in children, because that seems to be a large area which is unexplored. And listening to you all, it's just amazing lot of areas where technology can be used. So I hope I can contribute with my clinical expertise and talk to you through some of the areas where in children where robotics can be used. So I am a professor in pediatric neurology, and I mainly deal with children who have epilepsy, where I think technology has a big role to play. And I also see a lot of children with disabilities, and I think that there is enormous scope there as well.
Yeah, thank you. Professor Choi? Professor Choi, you can.
Okay, can I share my slides?
Yeah, sure.
Can I share my screen? Yes, yeah. Okay, give me a minute, yeah. Yeah, sorry.
Yeah, okay.
Yeah, okay, so maybe I go to, okay, a brief introduction to myself. I'm Chui, Chui. So I'm with the mechanical engineering in US. So we did quite a fair bit of things: medical device, robotic imaging, and simulations. So I also try to see how we can actually the technology that we develop for medical application can actually be applied to other area. So actually, I started doing medical simulation, in mid 1990s. So there was a project between Singapore and Johns Hopkins University. So we want to develop a simulator for interventional radiology. So it's very much like a flight simulator for pilot. It took a long time to train a qualified interventional radiologist. So the focus is actually on the provisions of realistic hand-eye coordinations. So there are a few things that we actually need to solve, a few technical issues that we need to solve. We need to have a good finite element. We need to have a good computational method to actually model the interaction between the catheter and the vessel wall, so that the trainee will actually learn the right thing. So I mean, also in the previous panel, we actually discussed a lot about the haptics. So the same thing for us, we experiment with haptics as well. But what happened here is actually with catheters. So catheter is actually going through a port. So somewhere somewhere like that, but you actually insert near, in this case, it's actually near the groin, and then you get the catheter up. So we actually kind of get a bit of a mix. Some say that the force feedback is very important. Some say that it does not. So we do a clinical, we experiment with the clinical students and obtain some clinical feedback. So actually at the end of the day, we are still not quite sure whether the force feedback is actually required. So the rarity on the feedback, I mean, maybe the force feedback may be required or maybe not. The visual one, at that point in time, we still need improvement. But I think, so this is a fluoroscopic view, this is the X-ray view that the interventional radiologists will be actually looking at. But with now current technology, this is not quite an issue. So, we do a lot of other stuff as well, like from the CT, MRI image, we construct the patient-specific vasculature system so that we can actually have a train of all the different types and so on. So, but anyway, this is not quite. This is very much like a flight simulator, a computer game. It does not actually teach. So about 10 years ago, we start working on having the RoPat being the trainer. So RoPat being the trainer, meaning that this is in collaboration with my clinicians, collaborating in NUH and A-Star Research Institute in Singapore. So we developed a RoPat. So what the RoPat did is actually we learn the motion from the master surgeon, and then after that transfer the skill to the trainee. I mean, essentially is to replace a hand-over hand type of training for laparoscopic surgery, and then at the same time, of course, the trainee have the options of after training, the trainee have the options of actually operate the tools freely. Operate the proof release and then compare with what the expert surgeon is, and then from there we actually can come up with some sort of scores and so on. We do some tests. We do some clinical tests with the children. Sorry, with the students, with the medical students. So currently what we did now is actually moving from the virtual to augmented reality. So this is our augmented reality systems. So one reason for that to move to the augmented reality system is that in an augmented platform, it actually provide some real object, and then so the real object itself. So what we have discovered for all the past years, the interaction, the computational method of modeling the interaction of the tools and tissue is very complicated. So by moving it to the augmented reality system itself, we may be able to introduce some real tissues into the systems for the training. And then currently the focus are actually very much on the RoPat learning the motions. So we have been using deep reinforcement learning of motions, and then so we also instead of focusing on hand-eye coordinations, we also look at the cognitive skill training, the tasks and so on. So with the augmented reality system and so on, we are looking at the surgical scene representation as well as the workflow recognitions. Yeah, so this is what we are currently doing right now.
Yeah,
thank you.
Thank you very much for the interesting presentation. Lastly, Professor Simon.
Sorry, let me unshare.
Yeah.
Sorry.
Hello, can I be heard okay?
Yeah, yeah,
okay.
can you?
Good.
Share, share, yes. Yeah, okay, yes, sorry. Okay.
Shall I go ahead?
Yeah, sure.
Please. Yep, I'm Simon de Lusignan. I'm a professor of primary care and clinical informatics at University of Oxford, and a practicing GP family physician, and practiced in my current clinical setting, including being a training and teaching practice for over 3 decades, I'll own up to. And I very much enjoy work, particularly with health data. And amongst other things, I run the College of GPs Research and Surveillance System, which is one of Europe's oldest surveillance systems, involved in flu surveillance for the last over 50 years. and more recently very active with COVID and facing some of the challenges other speakers have spoken to earlier in this session on the difficulty of teaching and training through the COVID crisis. My involvement with robotics has been through working with Thrish Nana Yakara at Imperial, and I've really enjoyed working on the RoPatient project. And the thing I've got most out of this is how it's opened my eyes to the limitation of our current approaches to training and teaching. And I'd almost want to echo, though obviously it's different in family practice where we're examining people rather than conducting surgery, but the lessons to me are really very similar to those talked about by our surgical colleagues earlier this morning. We used to have this idea that we watched one, we did one, and we taught one in terms of things with patients. And I suppose I've seen over the years when you've had a new student who looks very tense, and I think it's not only about finger feeling, but your arm tension and perhaps whole body tension, going to examine things, how clearly someone is not going to be able to feel the thing that they're setting out to feel or examine correctly because they've not had the any training or education in how to do this. And I think the real potential through this work with RoPatient and other things to develop the things being taught of about haptic feedback and things so that people can calibrate the way that they're working and examining patients in a way that was never possible in the way that we traditionally train people. So I'm really very excited, like many other people on this call, about the sort of things we're doing and its potential implication for clinical training in particular, but perhaps also for those of us who are experienced clinicians to knowing whether what we're doing is likely to be achieving what we're setting out to do.
Yeah. Thank you, Professor Simon. Thanks all for your short introduction. Okay, without further ado, let's start the main discussion. So my first question is related to clinical practice, and hence this question is for Professor Jithangi. What are the type of information or sensation you look out for during medical examination? And the follow-up question, how do you train medical students to interpret this information?
Okay, so I think probably I might be echoing some of the things that we have been discussing already. I think let's take so I'll be more talking about, like, in my setup where, it's related to training in children in pediatrics, and as you would know, they are very difficult customers, and also in general, even medical students, even young doctors, like examining a small baby is difficult, and also there's so much of, like, apprehension, and also handling a baby. You have to be, have to have a real reason to examine, particularly when it comes to neonates. Like, it's not easy having access. And just like our surgeons described how there is limited access to operating theaters, like, setups like neonatal ICUs, where touching the baby is very limited only to the caring doctor. So real exposure and experience for the students is actually limited in our practice in certain circumstances. So parents also don't really like, many people examining babies unless it's really a reason for the baby to be examined. So I think in medical education, in my field, I find that there is a lot of scope for simulation and for use for training, students on, common things like, for example, everybody needs to know how to examine a neonate, but, really having access to do that very often. And it is a meticulous examination, which takes time and it requires practice. So if you could have a simulated situation, I think it really would help. And we can see how, their access to patients has been curtailed because of COVID. And also there are situations when we have very sick children, children who have, like, conditions like immune deficiency, where it's just not possible to see them or expose them. So I think there is a big scope in that. And one aspect that we did not discuss at this point is, I think it could come in handy in our evaluations as well, because right now, okay, we have a system where we, score, we try to be objective, but it's all visual based. So I think in our assessment of students, as well as even young doctors or who are, budding to be physicians, pediatricians, we could have the situation where the patients, maybe not poor cooperation, things like that may not really hamper their evaluation process, and the evaluation can also be made more objective, I think. So that's with regard to medical education. Some of the examples that I can quote from my field, but I think I have different aspects that I can bring out with regard to the role of technology and robotics in medical practice. So first of all, I would like to take the same situation that not only students, but we face with the difficulty in examination. So in children, there are many aspects which are very difficult to examine. For example, you can never, we check the, one of the fundamentals is we check for the pupillary reflex. You cannot do it in a child, because the moment, they would, in the younger age, you shine the light, they close the eyes. So it would be, it's a valuable clinical assessment. So if the technology can do it for us, it would be, very useful. And in children, in neurology, we check to see how well you feel pain, how well you feel, how much you can see. Well, in the younger age group, when the findings are, they cannot express, plus their findings are not reliable, and they are very poorly cooperating to your examination, I see enormous scope with use of technology. So for me as a neurologist, I find it so difficult really to judge whether my patient, my client can see, very well. See means like, how well he can see. Can he see all the entire visual field, or is he just seeing one half of it? So it's very subjective assessment. So I feel that, I wish that technology would make my function easier, so that, I have a more reliable assessment of aspects which I cannot do in the real, situation. So, some other aspects with regard to, okay, examination, and then comes your assessment, your scorings, your scalings to, to judge, maybe the severity of a condition, and, how far we need intervention. So I find most of our judgments are, they are based on certain aspects, but they can be made more objective. So I think if I give you an example, it may be easier to understand. For example, in children who have what we call cerebral palsy, that's those who have early brain damage and they have limitation of movement. So we check for certain things as to how good their movements are, how active they are, and how much of disability they have, like how stiff their body is. So most of those assessments are actually based on subjective assessment. So it's how much I feel, how much do I think that the child is having stiffness in the body. But if I can use technology, or if I could use a sensor, which would not be affected by the child crying, or the child, not being very cooperative, I think it would make my, evaluation probably more objective. So, for example, use of EMGs and use of sensors, use of, different technology which could use to assess the degree of resistance in a more objective manner, I think would make our clinical assessments probably more reliable. And also it has the advantage of, being used repeatedly. So in our assessments, repeated examinations again become a problem, because, I think, like if I may quote what from the first panel, Professor, I think Kiguchi was talking about use of images. So you could store the images, and then you could, here it's like, I could use a video and compare, but it's just my subjective assessment of the video versus, the current situation. Or often there's no video, we actually think of what it was yesterday and we try to, reassess today. And then it's a visual assessment of how much of, say the gait has improved in a child. So if you could have a sensor which could do it, and also the sensor would be using the same parameters, and also the sensor could compare the image that was there yesterday and would be able to give probably a better and a more objective evaluation of how much the patient has improved. So I think, these are things, and in children, it's so difficult to perform. So therefore, I think there is a lot of scope in doing this as well. So the third thing would be therapeutics. I think obviously there's scope for therapeutics. We heard from the surgeons how robotics is used, but I am sure, like, if I talk about the two main areas that I deal with, like rehabilitation, in an older person who has a stroke, it's very difficult to instruct the person and, explain, this is what you're supposed to do. This is what you mean by active movement. But in a child, it's so difficult to do it. So maybe having like a robotic arm or a robotic game, or all interventions have to be like based on the age of the child. You cannot do the same thing that you do in a 6-year-old in an infant. So their repertoire of activities, repertoire of play, they're so different, and then they are in a dynamic process where it is evolving. So I feel use of robotics and particular skills that they know, utilizing those, and then having processes which activate particular areas, and getting the robotics to do some of the difficult tasks would really be useful. And I think, again, going back to what one of the first panelists discussed about, remote therapeutics. Like, for example, now when I am using Botox, I would need the radiologist. I need I also need the help of the neurophysiologist. So they all have to come to the theater, and then there is so much of overcrowding. And then, so if we could do all these things remotely, I think the therapeutics can really be improved as well. So finally would be re-evaluations. I think I've already alluded to the fact that re-evaluations are, I think, ours can be improved and become more objective than what we do now. Repeating tasks is difficult, so I think there is scope for re-evaluations as well.
Yeah, thanks a lot. That's a really interesting answer. So in line with that answer, my next question is directed to Dr. Tom. This is my question. So what is the role of medical robots can play during medical examination? And then how robots can assist doctors in medical examinations?
Yeah, I think a lot of what has already been talked about comes up here. I mean, robots have a number of potential advantages over even the best kind of doctors and physicians, in that they can be very consistent and very accurate. So they are able to perform an examination in exactly the same way every time, and to perform it exactly as required, essentially every time, assuming, of course, you program the robot correctly and all of that kind of stuff. Beyond that, there is also potentially a lot of different sensor information that can be collected by robotic systems, possibly beyond what is currently or traditionally collected by doctors, that may be able to give some additional insight into the patient. And then, of course, there is also the potential to use robots for remote diagnosis and remote performance of procedures, where, I mean, I think that the COVID situation, as we've seen, developing systems like this has potentially become a bit of a priority, where it's possible to evaluate people with infectious diseases or who are otherwise unable to be examined for whatever reason, using robotics. And I think, yeah, so I think that those things are really, there's the potential for using robotics for diagnosis that is quite large, and I think those fields are kind of the obvious ones to focus on. Yeah, thanks. That's very interesting.
Yeah, so since we already discussed a lot about robotics in medical examination, I want to ask this question specifically for Professor Chiu on virtual reality. What are the challenges for developing virtual reality or augmented reality platforms for medical training purposes?
Okay, I think, yeah, I think the previous panel, I think somebody mentioned about the virtual realism, all those things. The virtual realism, the computer graphic have progressed, have advanced very significantly over the last 20 years. You have very high-speed graphic cards and so on. So the virtual realism itself, I think is there. So you can create things that visually very clear, very realistic. But the problem here is, but there's still a problem. I mean, in my field, for example, I mean, for what I'm currently doing, I'm basically doing making a robot trainer. So robot trainer is, I mean, the robot is actually meant to train the human. I think the problem here is the intelligent part. So the intelligent part, I mean, in the accuracy of the physics. So for example, the tissue deformations, when you actually cut the tissues, and then how realistically it should be. I think the bigger problem here will actually be the blood flow. So for example, if you cut the tissue and then the blood start flowing out, and then the tissue deformation within the organ, and then the boundary condition is very well defined. So I don't quite think that the computational model is actually there yet, and I'm not very sure how far we can go from there. So the first thing that I think that's limited in this virtual simulation itself will be this computational model, or maybe to be more precise, will be a realistic biomechanical modeling. So and then the therapy itself is actually more than just deformation. Also, you may actually burn the tissue, and then once you burn the tissue behavior, the tissue properties actually changes. So when you actually cut, it actually behave differently also. And then because of our focus in actually doing in making a robot trainer, I mean, beside the realism itself, we actually want to provide add-on, value added to the visual scene. So it's not just the realistic itself, the realism itself. We also want to provide something called visual cue. So, like for example, if you are about to do something wrong, so you are supposed, or you actually exert too much of force and all those things. I mean, how we actually can best feedback to it. So, so of course, haptic have been around for many years. We talk about the haptics and all those stuff. So, but actually, when you, I mean, but it's actually for all this minimally surgery, laparoscopic surgery is actually go through a port. So a lot of time, this sensing can actually be mute. And then we actually perceive visual a lot more than the haptics. So in this case, we are actually looking at visual cue. And then, so how to actually best present this visual cue to the trainee. And then, I mean, we also experiment on audio cue, but I think we essentially learn very much from what we see. So yeah. So I guess these are things that I think a virtual simulation will actually be lack of. Augmented reality will actually have probably will be another level of training, or could be another level of challenge.
Yeah.
Thank you.
Yeah, thank you very much. This was very informative. So based on the points that we discussed so far, my next question will be pointed to Professor Simon. So as a clinician, if you are given a chance to select a training platform for primary medical care, either using fully virtual system like what you mentioned, or active physical mannequin like a robotic patient, what would you select and why? And then what features you would expect from such a system?
Okay. Well, I also need to know how much I can argue with the chair. Am I allowed a bit of both, or do I have to come down as one or the other? I mean, ideally, there are some things where you can see advantages for each. But if I was allowed one, I would go for the robotic patient. And I'll say why. I've a limited experience with virtual reality. But for example, where locally a new hospital opened, from the plans, they created a virtual reality ward and orientation thing. So, and you can imagine for students going to different firms all the time, that virtual reality of where you're going on your placement or how the operating theatre is laid out would be really useful. I've been on a fascinating virtual reality journey at an exhibition I went to where you were a sort of blood cell and you really got a sense of you know, how the circulation might work. But our course clinical skill is around interacting directly with patients. Obviously, communication with them comes top of the list, but a very close second comes the need to be able to examine people and to differentiate whether this is a case that needs urgent attention or not. And I'm probably going to focus in talking about this on clinical assessment, and particularly examining the abdomen, because that's where we're working on robo patient. And also I think it helps focus mind on what we're talking about. And I guess the first thing I'd sort of almost pose to everybody, particularly those of us who are experienced clinicians, is when did we actually learn in our careers? When I was a medical student, you didn't have an oroscope and a telescope looking in the ear that you held in your hand. You had a funny mirror with a hole in the middle that you had to focus a light down the ear hole. And to be honest, I didn't really ever see anything. But you had to sort of nod and smile to your teachers, or you'd be sort of humiliated in the group and get tense and get even worse. Similarly, it was alluded to by my pediatric colleague. When did I really start being able to focus on the retina and make a judgment about it? And with the abdomen, I find this, you know, I've got, it's quite a hard question to answer, but I think after my training, after qualifying as a GP, it was only after a couple of years practice that I felt really confident. And so I think the learning process is a lot longer than perhaps we own up to. And also we've got no objective measure of when that skill plateaus, or if we're all throughout life on a learning curve, or people like me are in the decline phase. I don't know, I hope not. And so if we thought about the abdomen and something really very basic, is do we know that clinicians always time their examination with when the patient is breathing? Do we know that people have enough pressure that they can feel things, but not too much pressure so that they cause too much pain? And I think there's nothing, you know, I've never, other than getting involved with Thrish and the robo patient, I've never had any feedback about whether this hand regularly causes my patient's pain. I don't think it does, or whether I'm using it adequately to actually feel the things that I feel I'm differentiating about. And they can be quite important. In yesterday's surgery, I saw someone I was pretty convinced did not have any sort of torsion of their testicle, and we are making these clinical judgments. And I think there is a real opportunity to, you know, things are not perfect yet. We haven't cracked this completely. There's a lot to do. But I think there's a real opportunity to both help students calibrate what they're doing, but also experienced clinicians, and also for us to teachers and leaders in medical education to actually know whether the curve towards optimizing what you do really happens as a student, or does it happen as a junior doctor as you get more experience, or does it actually take a couple of years in a senior role before you're really doing things right? And to me, no objective measures of these, and there are real opportunities to start acquiring them.
Yeah, thank you very much. Yeah, okay, now it's time for everyone in the Zoom meeting or our participant in the YouTube channel to ask any questions. Yeah, if anyone have a question for this panel.
I might just ask one for the clinical my clinical partners on the panel here. You've spoken a little bit about, especially Simon, you speak a little bit about advances in technology that have happened as you've been practicing. How do you find that that you adapt to those changes in technology as you've been going throughout your career? I imagine that you've seen some pretty significant shifts. Are they easy to adapt to, or is it sometimes an issue? I'm interested in your thoughts on especially as robotics and things like that become more common, the adaptation of clinicians to those changes.
If I may, Chad, I think with a very small c, what makes family practice and medicine safe is we're all very conservative in a conservative, not a political sense. I think in the things I've done generally in informatics, I think only lawyers are slower than doctors, maybe nurses are just behind doctors in readily adopting technology. And we've seen, for example, COVID has been great for me on my technological side. We don't issue any more paper prescriptions. We're doing all, and these things enable things. And we need some sort of trusting small steps. I mean, I wish, for example, I had in my waiting room, which we only allow the immediate person waiting for the next consulting room, a sort of robot that could clean the chairs, very basic, because if we had those things happening rather than a human doing it, it would start engendering that trust and confidence that's needed. So I think there's a lot written about the barriers to implementation and adoption of these things, and we really have to work hard at that. There also seems a hump about it that in the middle of the careers, when people are busiest, it often feels it's hardest for it to happen, whereas you can go for the younger people, and the people towards the end of their careers maybe have a little bit more time or a little bit more reflective about what they do. But yeah, that implementation really needs incentivizing and lots of work to get it to happen.
Yeah, thank you. We have another question, but unfortunately, time's up. So perhaps we'll try to answer that question at the end of this session. Thank you very much, Dr. Tom, and then Professor Choi, and Professor Simon, and Professor Jithangi for having with us and share your valuable thoughts. And then I'll hand over this session to Luca. Thank you.
Thank you, Thilina. Hi, everyone. I am Luca Scimeca, and I work in the Bioinspired Robotics Lab at Cambridge University, and I will be the second chair for this third panel. And I'd like to invite all the speakers first. So I'd like to invite Dr. Randy Koh from the National Heart Institute of Malaysia. I'd like to invite Dr. Arvind Valdivelu from Melbourne University, Australia. I'd like to invite Professor Shinichi Irai from Ritsumeikan University of Japan. And last but not least, I'd like to invite Dr. Nana Singh from the Indian Institute of Technology, Delhi. Without further ado, then I'd like for each speaker perhaps to give us a brief introduction of who they are and what they do. And so perhaps Dr. Koh could start. I think you're muted at the moment.
All right. Can everyone hear me?
Yes.
All right. Good evening or good morning to everyone. My name is Koh Hui Beng. I'm a cardiology fellow currently in the National Heart Institute in Malaysia. So thank you for inviting me to share my perspectives on how technology or maybe perhaps robotics can be applied in at least my field. Well, I'm not really an expert in robotics, but probably maybe I can share in the field of technology, in the field of cardiology is a vast technology in the field of cardiology. For example, in the intervention side, in the diagnostic side, for example, when we want to assess the coronary arteries to assess for any plaque burdens. We can do a CT scan, and then the CT scan is able to give us a quantification of how much the plaque burden is in the vessels around the heart. And that will also help us in guiding us on what to do during the angiogram procedure. And other things like, for example, a nuclear scan or technetium scan, where we do a functional assessment and where we can decide whether or not how aggressive we need to go ahead in terms of treating the coronary artery disease, whether is there any benefit of, for example, stenting that particular area when we know that there is no ischemia, when there is no perfusion defect to the myocardium. And of course, there are other things in terms of diagnostics. For example, loop recorders, for example, it's like something like a small device where you implant it underneath the skin, where sometimes we don't know, some patients will have unexplained falls or syncopal episodes when you do an ECG, you don't see any abnormal rhythm. So sometimes what we can do is implant a small device, we call it a loop recorder, and then the loop recorder is able to pick up any abnormal readings, and that any abnormal rhythms can be transmitted and then can be alerted to the clinicians that something is happened, and then we can able to call the patient back early for review and whether you need to implant any device, for example, an ICD or so on and so forth. Of course, other things, there are all other things like monitoring purposes in the coronary care unit, the cardiac monitors, which will have a continuous ECG reading, for example, where it will alert us when there's any abnormal rhythm. So all these technologies definitely helps us in managing the patients in the critical care unit, and also during the angiogram procedure as well. Certain imaging procedures like intravascular ultrasound, where they will help us to guide us to assess the lumen size and what is the size of stents that we need to use, what our strategy is. That will help us to get an optimum results during the percutaneous coronary intervention. So yeah, there's a lot of technologies which should definitely assist us in the field of cardiology. And I think there's a lot of technologies out there which waiting to come. And I think I've also come across as well robotics when they're doing the coronary angiogram and angioplasty using robotics, and where the clinicians, after they engage the catheter, and then they just step aside, go into the console, and then you just maneuver the wires and all. But I do not have the experience. I've only heard and read some of the articles, but never really had the opportunity to have first-hand such technologies, which I think can be good in the sense that, because when you do coronary angiogram, there's a lot of radiation involved as well. So if you can minimize radiation to the clinicians, of course that will be beneficial as well. So yeah, I think there's a whole it's a promising future in the field of cardiology. So I think we are always open to new technologies and ideas which can benefit us as a clinician, and at the end of the day benefit the patients. Yeah.
Great, thank you, Dr. Ko. I'd like to invite next Dr. Wanigashinghe to probably give us a bit of a talk of what you do and your expertise.
All right, thanks, Luca. Just briefly about my background, because I've had a fairly different clinical pathway compared to most clinicians. I was formerly training in neurosurgery before opting out and moving on to ENT. I had the privilege to work with the pioneer of robotic head and neck surgery in Australia, Professor Suren Krishnan at the Royal Adelaide Hospital. And it was from there that I then decided to pursue research in robotics, but not the clinical side, but actually the engineering and computer science aspect of it. So I ended up in London, actually at Imperial College, at the Hamlin Center for Robotic Surgery with Professor Lord R. Darcy, as well as Professor Guangzhong Yang. And I got to know some familiarity with some of the technologies which I applied in robotics and image-guided intervention. after that, I returned to Australia, and I'm currently with the ear, nose, and throat department at the INEA Hospital. And I'm actually probably the only clinician that I know in Australia where I'm pursuing a PhD in engineering in surgical robotics. So I'm working with the bionic ear right now and looking at some fairly advanced sensors for the cochlear implant. That's the bionic ear. And if you don't mind, Luca, if I just can share a video with you. So I actually presented this at the Engineering and Medicine conference at Berlin last year. So these are fairly advanced sensors. They are optical fibers sensors, which are actually embedded within the cochlear implant. So what you can see is actually an electrode of the cochlear implant, and you've got fiber optic sensors embedded within. And the whole idea is the surgeons, when they insert the cochlear implant, they can't actually perceive the force when it actually touches the sides of the wall of the cochlea, or whether it's going into a different chamber. And studies have been done where the perceived force is about 24 millinewtons by surgeons. But in reality, the injuries which occurs at the time of the insertion is less than 10 millinewtons. So these sensors that I'm working on actually detects force readings at 4 to 5 millinewtons and so on. So there's more to this research. It's a subject of a patent application, so I can't say more to it. Yeah, that's my current work right now. So I'm just going to move on to my pitch as well as to what is my vision for robotics. So I think the ongoing pandemic has essentially exposed the extreme shortcomings of public health. Furthermore, the indecision of the existing healthcare systems has been exposed, and this is quite obvious to everyone and clearly seen in both developed and developing nations with severe consequences to people's health and the global economy. So what I believe is required is an accelerated adoption of medical robotics within various levels of healthcare, from primary care to tertiary care. Robotics is one of the technology enablers in view of the availability of big data, providing the existing platform is linked within a health informatics system. This in turn should be fully integrated in the digital economy, which is what everyone is saying is the fourth industrial revolution. However, having said this will result in a digital divide with respect to clinicians. That includes myself, but simultaneously, it's inclusive to the consumers, that is the patient, as it will be patient-centric. So this can be achieved by focusing on customer experience, data-driven services, as well as predictive clinical performance based on analytics. The health security state that the world is going through provides an immense opportunity to rapidly prototype, test, and iterate patient-centered designs. So the end goal should be a prescriptive analytics model that is akin to a personalized medicine, where artificial intelligence provides a cost-effective and immediate real-world impact.
Yep, thank you, Dr. Mandela. That was a good answer. Next, I would like to Professor Hirai. What was yours?
Thank you. So I will share. That's right. Okay, can you see the slide? Okay, so my name is Shinji Hirai, so they're from University. So I myself is the applied mathematician, so in mechanical engineering. So now I'm studying the robotics area. Okay, so here I'm just introduce two topics in this area. Okay, so what is called surgical simulation? In flat foot surgery. Okay, we have now use the finite element simulation. Of course this is the traditional technology, the existing technology. But So the such okay, so this is a collaboration with the surgeons. So of course they are not familiar with such such technology. So we are now tailoring this technology that can be applied to the flat foot this surgery simulation. Okay, now we are doing several operations, simulating, and also we show how the surgical parameters. So in this case, the cutting angle and cutting length, so on. So how such parameters would affect the result. Then the surgeons can decide which is better. So they can choose the appropriate operation. And also this another one, so the second one. So this is the oral care, the simulator. In this case, a physical simulator. So the nurses, they have to learn the oral care skills, in medical school. But up to now, they are using such kind of how to say, mannequins. But of course there are no force sensing the capability. So that's why it is quite difficult to teach the force sensation to be applied. So that's why we are now making physical simulators. In collaboration with the dentist and also the professor in nursing department. So first we have developed right left one, this one. So here we have put many sensors for each tooth. But it's somewhat quite complicated, and it is not scalable. So we have decided to change something. So here we have only one 6-port sensor, but just attach the existing this simulator, we can detect kind of contact point. So here we have something, we can estimate the force and the contact point based on the geometric data of the tooth. Okay, so this is what we are doing now. Thank you.
Thank you, Professor Hirai. And finally, the last speaker is Dr. Singh. If you'd like to introduce yourself. So I think, yes. So unfortunately, because of different time zones and so on, Dr. Singh couldn't join us today. So we can actually just start early in the discussion. I actually have a lot of questions in limited time since we ran a little over before. But I'll start with Dr. Ko. So I'm actually glad that you said that your background isn't necessarily robotics or you don't have that much experience with it, because I actually wanted to know from the perspective of a medical doctor, which doesn't necessarily have an insight in the technology of robotics, what kind of technologies you think would be most useful to you for what you do every day. So what kind of technologies do you expect in the future, say 10 to 20 years, and what can roboticists or engineers give you that really would help you in what you do?
Right. So the bread and butter that most of us do, or at least in training, is to do coronary angiograms. That's the you need to be a safe doctor to do a coronary angiogram, looking at the coronaries of the heart. There are models, plastic models, where you can practice doing this, specific ballooning techniques, putting the stents to open up the clogged arteries. But those are models, static models. In the everyday that we do, we are dealing with human beings, a moving heart, a constantly moving heart, where when you put in a catheter, the catheter is moving. So you need to train your eyes on the monitor, on a moving heart with the wire there. You need to know, estimate where is the balloon going to be. So as a trainee, when I first joined, I was very scared. Obviously, you don't want to mess up the heart. You can cause perforation, you can cause bleeding can happen. And of course, you have your seniors by your side, you have your mentors at your side, you have your consultants at your side, by your side. But by the end of the day, you need to build up that confidence. So I think it's good that they be on your side, but I think if we can have some form of technology which can mimic the movement of the heart, the heartbeat, while you're doing those kind of procedures, then that somewhat gives us a real-time feeling, if you like, that we can perform the procedures and learn at the same time. And we don't want to experimenting or practice it on a real life patient too quickly. Of course, eventually everybody has to start somewhere. As a patient, I think they probably wouldn't know that you are a fresh trainee meddling your heart, but it'll be nice to be reassured that someone who is meddling your heart is someone who's experienced enough doing all these high risk procedures. And then of course there are other things that life and death matters, emergency procedures. For example, when you have when you have fluid around your heart is moving, you have fluid around the heart, you have to insert your needle to try to decongest the fluid around the heart. The heart is moving. So as you put your needle to decompress, there's always that risk of the needle puncturing through the heart. All right, so those are emergency procedures which we have to do. Of course, we do it under the fluoroscopy guidance and all. So again, if there is such a technology which we can practice on doing such thing, and if we really do something wrong, and we, like for example, we actually punctured the so-called robotic heart, and then as we know, okay, you failed, so you have to try again. So of course, all this kind of thing, which not to my knowledge, I've not seen one done, but it's all these procedures, high risk procedures, is always we are learning as we go along. So I'm thinking like, why are we learning as we go along if we can start somewhere? Build our basics, build our foundations proper, and then of course, and as you learn and you go along, you get the confidence, you can perform in a more confidence, and also in a calm manner, because it's not something new for you. Yeah, that's my take.
Yep, great answer. Thank you. This is actually very to the point. I actually wanted to ask Professor Hirai, from your background in soft robotics, and what kind of actually technologies you think are at the bottleneck right now. So is it a matter of material science? Is it a matter of, well, I think we talked about simulation and we talked about haptics as well, right? So what's missing? What steps should we take next?
Okay, maybe so one candidate would be kind of active materials. So we have some material scientists now working on the materials. Okay, that's where for example kind of vibrate, or kind of will move according to the external signals. For example, the electric, or kind of change of pH or kind of temperatures. So maybe such kind of materials can be applied to the so-called kind of real kind of fake organs for the surgical simulation. Of course, we are now pneumatic on or kind of hydraulic actuators, hydraulic actuation available, but maybe more kind of material side research, I guess, needed for the future direction. Thank you.
Thank you. That was a great answer. So actually, before really closing this, I actually wanted to bring up an issue that I think is very pertinent to what we do. So there's always this duality of doctors and on the technical side, maybe roboticists or engineers, and it seems quite hard sometimes to bring research forward, because there needs to be a synergy between these two parts of the same coin. And so I know that Dr. Van Velo wanted to say something about this. How do we bring these two communities together? How do we build a relationship such that we can make fast progress and really target those areas of research which we need to target for this area to go forward?
Well, to start off, I think we need the right environment, and I suppose the pandemic actually provides the exact perfect scenario. If I were to quote former Chief of Staff during the Obama administration, Rahm Emanuel, he said that never let a good crisis go to waste. I understand that it's difficult times for lots of people, but we have been forced into this situation where all of us need to adapt technology into our daily lives, whether it's routine or work-related, and particularly in healthcare. I think this is the right time for all clinicians and also people from the technical side, whether it's engineers, computer scientists, people who specialize in AI. I suppose, Luca, you're from AI as well, to really get on to the task ahead and solve all these problems. I personally feel from the clinician side, because this is what one of the engineers has told me before, that they have a discussion with the clinician, say for example it's a surgeon, and the surgeon thinks he or she knows what they want. And when the engineer comes back with the solution, it appears that this is not exactly what they wanted in the first place. So there's a lot of miscommunication between the technical side and the clinical side. I find myself, though being a clinician, I'm being sort of like being forced down this part where I'm between the clinicians, my consultant surgeons, and engineers. And I feel quite comfortable being in that position because I've had like 18 years of clinical experience and also about 5 years in engineering research as applied to medicine and surgery. So I think it starts with clinicians first, being humble and accepting the fact that we need to understand the technology. We need to know the engineering principles, the computer science behind the adoption of robotics and AI as applied to medicine. So that's how I feel that everyone can come together. Because based on my experience, well, when I was at Imperial, we were quite lucky in a sense that we had different colleagues from different backgrounds, but surprisingly, there were still two camps. There was eventually the clinical side, which was based at Paddington, and the technical side, which was based in South Kensington, which doesn't work if everyone wants to be in the same page. So if you see how the Russians and the Chinese are going about it, I think that seems to be the right part for me. If you've heard of the Moscow International Medical Center, which is based in Skolkovo, in Southwest Moscow, they've got this whole setup in one precinct. And similarly in Shanghai, the Medical Robotics Institute for Shanghai Jiao Tong University encompasses 3 hospitals, fundamental or basic science research, applied science research, as well as an industrial park. So we've got no choice. We've got to be forced into this situation and work together. And it needs to be continuous feedback. Particularly my criticism is towards the clinicians. We can't be in theater 5 days a week and then meet up with our technical colleagues maybe once a month, once 3 months. That's not going to work. There's going to be continuous collaboration, and I reckon that if we were to actually come up with rapid prototyping and then to test it and then iterate it. There's no other way. And look, we are in the right time at this moment. This pandemic is going to go on for who knows, maybe years. So we could never we couldn't be in a better position to solve these problems that are facing us. Is that answer, Luca?
Yeah, absolutely. No, this is great. I think I agree. We're in a very important time, I think, at the moment, and we're almost setting the stage for how to carry on research in the future, and you know, what are the steps really to make this happen. So, unfortunately,
if I just could add on, right? Because I'm also, assisting one of the laparoscopic surgeons here in Melbourne, and I assist him with holding the laparoscopic camera. But at the same time, I'm working with an engineer where we can develop a shared control mechanism so that the laparoscopic holder can be replaced by an automated device. So which means that I eventually get kicked out from theater, but I'm okay with that, right? So I think clinicians need to be far-sighted in the sense that there are a lot of tasks there, if it's targeted right towards the right discipline or right task, in whether it's in interventional radiology or surgical robotics or even primary care, then we need to take cognizance of the fact that there are some tasks where we will eventually be replaced by a semi-autonomous or maybe even autonomous, who knows?
Mm-hmm. Yeah, this is actually a very interesting discussion. I'd like also to hear Ko's opinion on this, but maybe very briefly. So we, after Ko's take, we end the panel session.
Sure. No worries.
So, Dr. Ko, do you think the future is added towards robotics being tools to be used by clinicians to do their job better, or perhaps there's also a venue for autonomous systems to, in a sense, replace operations?
I'll probably should go hand in hand. I think to replace, I guess there's still that there is that EQ side, I guess, that we need to weigh in the. Let's say, for example, we have a very tight lesion, the stenosis all around, and then the robotics, for example, says that you need to open up everything. But the heart function is so poor and the patient is already at 90 years old. You know, the risk is high. Of course, you know, on paper, you need to open it up. But patient is pre-morbidly bound, you know, they are not really walking, they're not really having a good quality of life. What's the benefit of doing that? So I think it's not just all, I think they go hand in hand, I think. Yes, definitely there is a role for robotics to assist us in making our decisions. But at the end of the day, I think there's still a lot of role to play. I mean, us as clinicians to decide what is the best choice. Yeah.
Thank you, Dr. Ko. So I think this brings this panel discussion to an end. We're running a little bit over time, but I'd like to thank all the speakers of panel 3, panel 1, and panel 2 as well. We talked about many interesting issues, including the coronavirus and the pandemic repercussions in terms of training and obviously the robotic side of medical diagnosis. And we talked about the issues of haptic sensing and soft robotics and other technologies which really need to be boosted if we want to make an impact in this field, as well as obviously simulation for the sake of training and possibly also diagnosis. So without further ado, I'd like to actually give the floor to Angela Faragasso, which is going to make an announcement. Angela?
Hi. So I would like to announce the Best Poster Award. And before, I would like to say that there have been a lot of very nice and interesting work that have been submitted to this workshop. And the awards were selected by a panel of judges. And we use some criteria like content, contribution, and readability of the presentation. And the certificates are awarded by the UK RAS Strategic Task Group of soft robotics. And I will present the Best Presentation Award, while Professor Maiolino will present the Best Presentation Award in the next section. And I'm pleased to announce that the award goes to Pilar Zankiu, Oliver Thompson, Yon-San Tan, and Bennett Cobley, and with their paper Acoustic Response Analysis of Medical Percussion using a wavelet transform and neural networks. Congratulations to the authors.
Thank you. Wow, thank you so much for this award. We really cannot express how grateful we are to be considered for the best poster. We wanted to thank you, Dr. Angela Farragasso and Professor Perla Maiolino for choosing the project, and also the organizers and the speakers, because the event and the talks on the future of patient care were wonderful. And it's such an honor to listen from experts in the field. And lastly, we want to thank also Dr. Thries and Dr. Nicolas Rojas and everyone else in MorphLab research group, especially Lian He, for your advice, mentorship, and support in the project. So without you, honestly, this wouldn't have been possible. So thank you. We really look forward for the rest of the event.
Okay, so now this brings this first session and panel discussions to a close. I thank all the speakers again, and we'll meet again for the second session in a few hours. Thank you.